Hello, case study 6. Hypothesis. The dural tube rock and glide technique for treating the abscess of spinal cord patient resets the central nervous system and aids in healing. The reason this hypothesis was chosen is because the therapist was keenly interested in discovering how much a gentle technique such as a dural tube rocking and gliding would be able to change the symptomology of his clients and moreover to reset their healing course. Health history. A 62-year-old female client presents with the history of serious lesions such as a left side benign cancer, which occurred 12 years ago, then 3 years ago an injury to the thoracic spine, which led to the spinal cord abscess (SCA). The client has had a 3 month recovery time, after which she was able to function normally. Our patient has a type 2 diabetes and a recent edema in her left ankle. Client also presents with the head forward posture, is obese and has an inactive lifestyle for the most part. Typically, the client complains of the achiness at the site of the spinal surgery during the weather change or after an active activity. The client's basic screening test reveals the following. Mitchell's screening test shows difficulty in global flexion at the bending of the knees, as well as reduced range in external leg rotation bilaterally. Left lateral side bending is better than the right side. Structural test shows a higher left shoulder, T1 to T8 rotated to the right and L1 to L4 rotated to the left, and her spinous processes T1 to T3 have been removed during the surgery. Sacrum is symmetrical. Moving to fascia assessment. Her body is showing an upper body cross syndrome from the lateral view. The fascia pool indicates the T1 to T3 area as well as the left T4 to T10 lateral rib pool towards the side and into the breast tissue, which was removed before. Moving on to the listening stations, we see that the scar for right leg and the left leg differs significantly. The right foot shows a 5 out of 5 quality, amplitude, and rate, while the left foot has a 3 out of 5 quality, 2 out of 5 rate, and 2 out of 5 amplitude. Very little symmetry bilateral. The thighs don't show symmetry, however, great amplitude and quality, 5 out of 5. Then ASAS are losing they are losing the scar to 2.2 out of 5, and respiratory thorax shoulders show the most poor scar out of 1 out of 5, sometimes not even being able to recognize any rate. Wall holds 1, 2, and 3 also reveal very little 1 out of 5 scar, making the therapist realize that we have a lot going on here. Biological determinants. Based on the therapist's observations, we can see that our client has had multiple lesions which are predominantly physical in nature. We have an example of a cranial lesion, which is unique, wherein there have been an infection found in the epidural matter within the intravertebral space. A little side note about the SCA, spinal cord abscess, is a swelling, irritation, or inflammation, and the collection of infected material, aka pus, and germs in or around the spinal cord. It is a very rare condition and a very dangerous one, as it can lead to paralysis or death when untreated quick enough. And since the infection was found in the posterior spine, the spinous vertebrae were removed to get to the lesion. It took our client 2 months to recover from this surgery. The psychosomatic lesion has happened 10 years prior to this incident, where the client was going through some major stresses in her life and was starting to develop a benign cancer in her breast, a psychosomatic lesion. As surgery and radiation therapy were applied to help her. Also, our client has a genetic predisposition to obesity as it runs in the family, and she developed a type 2 diabetes that created a complication with the recovery rate of spinal cord abscess. The edematous swelling on the left ankle is a somatic lesion which we don't know the cause of. However, it looks like a possible small arterial rupture. Other than that, she is very positive individual with a great outlook for her future. What may improve our overall health of our client is her attendance of the health clinic, regular visitation to the physician to address the ankle swell, the type 2 diabetes, and high blood pressure. Moreover, the therapist would refer her out to attend the physiotherapy clinic to improve her head forward balance issues, dietologists for learning how to balance food, and of course the regular osteopathy treatment. Time frame of the study. The study is based on 3 90-minute treatments. Each treatment consisted of a 10-minute assessment, 60 minutes of actual treatment, and the last 10 minutes of reassessment and home care instructions. Informed consent has been agreed upon, satisfying the partnership principle. Tools used. Hands only are used for palpation skills to figure out the fascial pull, to read the cranial rhythm, and to measure the 4 T's. Special tests such as Mitchell screen test, fascial pull test, bowstring theory, listening stations of cranial rhythms were utilized. Patients' objective and subjective findings, such as a state of well-being on scale from 1 to 10, is used to measure the neurological reset. The health history form was taken to monitor and record the data of our patient. Results. Our client has had an improved sense of well-being, rating herself a 7 out of 10 in terms of well-being. The other observation is that her rotation and left side bending improved along with the decreased level of tiredness during the physical activities. She noted that she felt as though her body got replaced with an innovative body. Objectively speaking, the following was observed. Posterior fascial line restriction, spiral line restriction were loosened. However, the fascial pull T1 to T3 and T8 to T10 left side rib were still there during the retesting, but not as obvious as before. The T4 to T10 and L1 to L5 counter rotations were corrected. The scar retesting shows improvement in cranial rhythm as well. The right foot shows 5 out of 5 quality, amplitude, and rate, while the DMS left foot has somewhat improved 4 out of 5 quality, 3 out of 5 rate, and 3 out of 5 amplitude. Bilateral symmetry went up to 2 out of 5. Thighs are showing better symmetry than ASIS, are boosting the scar to 3 out of 5, and respiratory thorax and shoulder show little increase in quality and rate, 2 out of 5. Wall holds 1, 2, and 3 also reveal better results, 2 out of 5 symmetry and amplitude. We can see that there is still a lot of work to accomplish. For the personal treatment plan, client has approved the treatment plan as proposed by the therapist. The convenience of location and freedom of our patient's schedule allowed us to be able to meet for 3 treatments within a 3-week period. As for our immediate goals, the client has agreed to stay more attuned to her health issues, to maintain regular exercise, and to visit a physician for blood pressure, swollen ankle, and diabetes issues. Now about the treatment plan. During our first treatment, the bone alignment issues will be addressed. We will closely target the Unity 3 and 1 through osteoarticular adjustments. Unity 3. We have corrected the twisting of the vertebrae L1 to L5 and T1 to and T4 to T10. At Unity 2, we have worked on the T-spine T1 to T4, kyphotic curve correction leading to C1 to C7 traction and MET sway correction. As we know, structure affects function, so that is why we have started with the bone alignment techniques first. Second up is fascia work. Being extremely cautious around T1 to T3 spinous processes, we want to follow the indirect fascia pull techniques that lead us to the origin of the lesion. The whole posterior, lateral, and functional lines were targeted. The home care stretches were given before the second treatment. At our second treatment, we started with the fascia pull assessment and the listening station scar before balancing our diaphragms and getting into the dural tube rocking and gliding, also into traction from the sacrum and of course the occipital release. Reassessment of scar was done at the end of the second treatment and the results were recorded. At the third session, we have addressed the reassessment of the unity's posture with screening tests and address the specific adjustment techniques when needed. Then the therapists have moved on to assessing the scar to figure out which diaphragm to balance out before treating the cranial bones. The dural tube traction from sacrum and dural tube rock and glide were performed before the OCB release. Cranial bones assessment and treatment of the temporal and sphenobasilar compression decompression was finished to the treatment with wall holds and steel point, and of course reassessment was done later. The cost-benefit analysis shows that this is a win-win case for both therapist and the client because there has been a mutual business agreement arranged that pleases the two parties. As for the therapist, this benefits him in the sense of gaining a unique experience in dealing with a spinal cord abscess holistically. And as for the beneficence-maleficence principle, there is no harm predicted in our study. One thing to note here, the therapist kept caution with the fascia work at the location of spinous processes removal site, which is T1 to T3, using only an indirect light touch techniques. The therapist does acknowledge that there are limitations to our study. First and foremost, the SCA is a very rare health issue. A professional surgeon will admit that there would have been no more than 3 times in the whole career, whereas they would have a patient with abscess of spinal cord. This is why it would be nearly impossible to get a greater sample size of clients to work on, let's say 5 patients or more. Secondly, there are multiple lesions in our patients' health which broaden our study attention, addressing various multiple lesions and spine corrections, fascia pulls, making it difficult to just have an objective observation of the dural tube improvement. And thirdly, through this short study, we can not see the long-range effects of the dural tube rock and glide effects unless we get a consistent monthly treatments and reassessment reports. The short-term goal for our client is to maintain a healthy balance between the diaphragm as well as keeping the cranial rhythm scar balanced through the regular tendon or osteopathy therapist. Also, the therapist recommended proper postural exercises and stretches that must be attended to daily, as our client resorts to her head forward posture as a compensatory pattern derived from the main lesion site. The long-term goal for the patient is to address the overall well-being, addressing her other issues listed, like working on the breast scar tissue, referring to the doctor for type 2 diabetes, referring to dietologist, naturopath for proper nutritional balance, also by visiting a physiotherapist for a proper exercise schedule. We also would likely be concerned with a neurologist and cardiologist to receive a more holistic balancing of central nervous system and cardiovascular system. And lastly, the podiatrist will come handy to look into the swollen ankle lesion. It is important to underline that osteopathy is playing a very important role in solving our clients' physical lesions through craniosacral rhythm and dural tube rock and glide traction from the sacrum work, as witnessed by the amazing results achieved in our study. An important note here is that during a first treatment, we wanted to contrast the results of osteoalignment and fascia work with the second treatment, wherein the diaphragmatic balance was followed by dural tube tractioning techniques. The first treatment allowed us to resolve the groundwork of the structure before we could get into cranial sacral one, which only complemented our results. In the conclusion, in this case study, the therapist has gained a significant clinical knowledge of assessment, palpation, observation, and treatment skills. We have introduced and tested the craniosacral techniques, the dural tube rock and glide and traction from the sacrum, and as it best suited with spinal cord injury persons, while staying loyal to the prerequisite osteopathy or osteoarticular and fascial remodeling techniques. Quite paradoxically, they all worked out to our best outcome when used together. The lesson is clear regarding the effectiveness of cranial dural traction release techniques in regaining the mental resetting of the sympathetic mode into the parasympathetic one, and allowing the space and fluidity to be created within the spinal cord, thus relaxing the wiring which stimulated so much trouble in the past. The client has admitted that this was a very innovative form of therapy that she has never felt before. Her amazement came in the following 2 or 3 days as she was starting to feel as though she was having a new body. Her physical work capacity increased significantly according to her, and the tiredness from the physical labor at the garden has disappeared. Therefore, we can conclude that the experience that has been gained here is surely valuable, and the therapist is going to use it freely in our future clinical practice when addressing patients with the various spinal injuries.